Welcome friends. I am Dr. Baldev Prajapati, Professor Emeritus and Director, Medical Education and Research, Baldev Medical College and Hospital Kadi, located in North Gujarat. These are my 4 books published in the field of pediatrics, particularly on procedures, signs and symptoms, clinical pediatrics, and very specific on OSCE, spotters, and viva. Today I am going to talk on cyanosis in children. How we define the cyanosis? Cyanosis is defined as bluish discoloration of skin, mucous membrane, and nail beds due to deoxygenated hemoglobin or reduced hemoglobin more than 5 gram per deciliter. In severely anemic children where the hemoglobin is less than 5 gram per deciliter, please remember cyanosis may not be apparent in spite of significant hypoxemia, and it is very easily missed by the clinician. Apparent presence of clinical cyanosis indicates that SpO2 is less than 85%, and that indicates the severity. What is the mechanism of cyanosis? It may be the central cyanosis. That means when the amount of deoxygenated or reduced hemoglobin exceeds 5 gram per deciliter in the capillaries, the blood appears dark, giving the tissues a bluish hue. And this is seen earliest in the areas with thin skin like palate, tongue, lips, conjunctiva, and nail beds. These structures are also warm due to increased capillary circulation and may be reason for early detection of cyanosis in these areas. Another variety is peripheral cyanosis, and it is due to the slowing of blood, which allows more time for removal of the oxygen, that is oxygen extraction by the tissues. It is visible on fingers and toes and may be seen on the tip of nose and even the ear lobules. Here systemic arterial oxygen saturation is normal, but here it may be due to the vasomotor instability and vasoconstriction following cold, venous obstruction, or even the polycythemia. It is more commonly seen in the newborns due to the hypothermia, very important cause. And on rubbing the hands and feet in this type of the newborns, or even covering them with the clothes, circulation improves and cyanosis disappears. Clinical examination of cyanosis is very important. Please again remember, look for cyanosis in the daylight. It makes difference in detection. The blue light, blue clothes of the child, and the blue curtains in the room may impart the bluish hue and may interfere with the proper examination. So keep in mind that surroundings blue factors should be removed. Again, methemoglobinemia and sulfhemoglobinemia are mimics of cyanosis. That means there is bluish discoloration in these conditions due to abnormal pigmentation. But if you see it, measure the SpO2, it is normal. And this cyanosis is based in the children with severe anemia and monoxide poisoning. So these points are very important when you examine the child for the cyanosis. Already we have discussed some of the types of cyanosis. Central cyanosis, that means reduced hemoglobin more than 5 gram per deciliter. Acrocyanosis or peripheral cyanosis, that means it is due to the cold, due to the vasoconstriction or stasis in a case of polycythemia. What is pseudocyanosis? Pseudocyanosis, that means spo2 is normal, oxygen concentration is normal, but still there is a bluish discoloration of skin and mucous membrane. That means here is due to abnormal pigments. Very classical two conditions should be kept in mind: methemoglobinemia and sulfhemoglobinemia. Third thing is differential cyanosis is the variety. Now, what is differential cyanosis? Here lower limbs are more cyanosed than the upper limbs, and it happens classically in a case of PDA with reversal of shunt following pulmonary hypertension. While upper limbs are more cyanosed and lower limbs are less or maybe the pink, and that is seen in a case of transposition of great vessels with PDA, but now present with the complication of pulmonary hypertension. And cyanosis of left upper limb and both lower limbs due to the preductal coarctation of aorta with PDA and pulmonary hypertension. So, these are the three groups with the differential cyanosis presenting should be kept in mind by the good clinician. If you look at the common causes of cyanosis in the newborn, particularly the cardiovascular system related reasons, most common is the transposition of great vessels. Maybe the tricuspid atresia, persistent pulmonary hypertension of newborn, tetralogy of Fallot's, abstinent anomaly, and truncus arteriosus as other causes. Respiratory causes presenting as a cyanosis in the newborns are hyaline membrane disease, congenital diaphragmatic hernia, bilateral choanal atresia, Pierre-Robin syndrome, severe pneumonia, pneumothorax or pleural effusion, or airway obstruction like vascular ring or some mass. While common causes of cyanosis in newborn, again if we see related to the central nervous system, the common causes are the asphyxia, seizures, intracranial hemorrhage, hypoglycemia, methemoglobinemia, and polycythemia. If we see the common causes of cyanosis in children related to the cyanotic congenital heart disease, most common is Fallot's tetrad, more than 75 to 80%. Others are Eisenmenger complex, single ventricle, abstinent anomaly, truncus arteriosus, and total or partial anomalous pulmonary venous return. Related to pulmonary, severe bronchial asthma, pneumothorax, severe pneumonia, massive pleural effusion, foreign bodies or AV fistulas. Friends, please keep in mind a word on methemoglobinemia. Here normal hemoglobin is iron in ferrous form, while in methemoglobinemia iron is in the ferric form. Methemoglobinemia may be of hereditary congenital variety or acquired, and usually the nitrates, aniline dyes, dapsone, primaquine, these are the known factors to cause this methemoglobinemia. And when the methemoglobin is more than 1.5 gram per deciliter, cyanosis becomes visible. Arterial blood is characteristically on puncture, even if you see it is a chocolate color, brown color, very important attention drawing, I will say, point for the clinician. But if you measure the spo2, it is normal. And friends, treatment of methemoglobin point of view, it is quite rewarding, that is methylene blue 1 to 2 milligram per kg, followed by bolus of 25 to 30 ml of normal saline. Here it should be given very slowly. The dose, if it requires, can be repeated after 1 hour to a maximum of 7 milligram per kg over 24 hours. Patients with G6PD deficiency should not be treated with methylene blue. Very important message for the practitioners. In chronic methemoglobinemia, hereditary variety, Vitamin C can be used in the dose of 200 to 500 milligram per day in divided doses and may be rewarding. Thank you very much. Friends, before I end, I request you to subscribe over this channel, and if you subscribe every time, you will get some new informations very useful in the exams and in the daily practice. Thank you. Thanks a lot.